Good afternoon, colleagues. Good afternoon, ladies and gentlemen. Well, as part of our Module 6 individual assignment, we're required to do a YouTube video on any topic of endocrine tumors. And so I have decided to talk about features of malignant thyroid gland. Features of malignant thyroid gland. Under this discussion, I'll look at a brief background of malignant thyroid glands, and next I will look at the classification of the thyroid cancers. There are several classifications, although they all point out to the same meaning, but those classifications are very much important because they help you in making the diagnosis and also for your management plan. And then finally, I'll look at the clinical features of the thyroid glands, all of the thyroid glands. Good. So as I said, the background. Thyroid gland is the cancer, is the most common endocrine malignancy. In fact, this is the reason why I have decided to speak about it, because there are other endocrine malignancies, but this is the most common. In women, it is the 7th most common cancer, and women are affected 3 times. Women are 3 times more likely affected than men. However, one should take note of is that the prognosis in men is worse than that of women. So this simply means even if women are 3 times more susceptible to this cancer than men, if they both have the condition, men will first die than women. Okay? With regards to prognosis, studies have shown that when somebody is diagnosed of thyroid cancer, there is a 5-year survival rate that they've checked. And generally, there is a 5-year survival of people with thyroid cancer is 98%. However, it's important that we note that this survival rate, it depends on several factors, like the staging of the disease and the type of disease. So if it's a localized thyroid carcinoma, we know what it means when a thyroid carcinoma is localized just within the thyroid gland. Then the 5-year survival rate is 100%. Most of these patients live for 5 years. But if the thyroid carcinoma is localized anaplastic thyroid cancer, then the 5-year survival rate is 31%. And if it's a regional follicular thyroid cancer, then the 5-year survival rate is 97%. If it's regional medullary carcinoma, then the 5-year survival rate is 91%. And if it's a regional anaplastic thyroid carcinoma, then it's 10%. So you see the percentage reduces from being localized to regional. This means the more spread it spread, the more worsen the prognosis. Okay, classifications. Well, some classification based on the cell of origin. So if the cells originate from the papillary cells, the tumor can be classified as differentiated or undifferentiated. So if it's differentiated, we have 2 classes. We have papillary and follicular. And of this papillary, the frequency is 80%. And of this follicular, the frequency is 10%. So under the papillary, the differentiated ones are papillary, which can occur up to 80% the frequency, and the follicular is 10%. And still under the papillary, the undifferentiated type is only anaplastic, and the frequency is 3%. Those that originate from the C cells, the cancer is classified as medullary thyroid cancer, and for this the frequency is 5%. And those that originate from the lymphocytes, lymphoid cells, they are classified as lymphoma, and the percentage of frequency is 1%. Well, as I said, there are other forms of classification. Well, it's almost one of the same. But there's another classification that classifies thyroid carcinoma as primary and as secondary. So for the primary, we have 4 classes of them. We have the follicular, excuse me, for those that are follicular epithelium, which are well differentiated, they are follicular or papillary. So for the primary, we have 4 classes. One is the well differentiated follicular epithelium, which can be papillary and it can be follicular. And the other is undifferentiated follicular epithelium, which is anaplastic. And we have the other ones from the parafollicular cells, the C cells, as I said, that's the medullary, and the one from the lymphoid cells, the lymphoma. Those are the primary. And the secondary is metastatic thyroid cancer. So more or less, it's almost one of the same, and it gives an idea the spread and the extent of the thyroid gland disease. So now let's start proper with the papillary carcinoma of the thyroid gland. For this papillary, the clinical features that will make you come up with a diagnosis as follows. Here, the thyroid swelling can be firm, it can be soft, it can be hard, it can be solid, it can be rigid. So whenever you see that protein type of swelling, variety in swelling of the thyroid gland, it is suggestive, gives an idea for papillary carcinoma. With the papillary carcinoma, another feature is the compression features. They are uncommon, as unlike others which compression can take place where maybe they can compress the superior laryngeal nerves. In this case, it is not common. It may happen, but if it's happened, it is very, very uncommon. Papillary carcinoma, they are slow growing and they may spread through the regional lymph nodes. So their spread is just limited to the regional lymph nodes, and this will give an indication of its prognosis. The nuclear size has a very large size with a pale staining ground glass appearance. So it's the nuclear size is very large and the ground appearance is pale staining. It's called a pale staining ground glass appearance. And this is referred to as the orphan Annie eye nucleus. So when you see this kind of feature, it is suggestive of a papillary carcinoma of the thyroid. 40% of these type of thyroid carcinoma, they form what we call laminated calcified sphere, also referred to as sarcoma bodies. Well, some authorities say this is a pathognomonic feature. So whenever you see sarcoma body, even though it occurs in 40% of cases, it is suggestive of a papillary carcinoma of the thyroid. Another feature is that most of these papillary thyroid, they secrete triglycerides, and these can be used as a marker for the recurrence or metastasis, because of the high level of triglycerides can produce. So in making a diagnosis, we need to check for triglycerides, and it can be used as a marker, especially in case of recurrence or metastasis. Another feature, as I talked about, in the case of the papillary carcinoma of the thyroid, none of these prognostic scoring system permits definitive decisions. When we go further into the lecture, we will realize that there are prognostic scoring features that we use to help us determine the prognosis of a thyroid carcinoma. With regards to the papillary thyroid carcinoma, none of those scoring will be able to pinpoint that this is a parafollicular thyroid carcinoma. A papillary carcinoma of the thyroid gland. Next is the follicular carcinoma. Well, follicular carcinoma, for this, the neck swellings can be firm, they can be hard, and they can be nodular. Neck swellings can be firm or hard and nodular. They may minimally or widely be invasive. So most of the time they can spread. The invasiveness may be minimal or it may be wide. It depends on other factors, right? But if they do spread widely, they can invade the lungs, and when they go to the lungs, they present with dyspnea, hemoptysis, and even chest pain may ensue. And if it invade the recurrent laryngeal nerve, then it can present with hoarseness of the voice. If the lesions infiltrate into the carotid sheath, then the Berry sign will be positive. This simply means the tumor has engulfed the carotid sheath, and because of that, the pulsation of the carotid sheath will be absent. And whenever pulsation of the carotid sheath is absent, it is referred to as a positive Berry sign. So, unlike the papillary carcinoma of the thyroid, which I said the scoring system I cannot make any decision. With regards to the follicular, it can. Two systems are used. We have what we refer to as the AMES, AMES clinical scoring system, and the AGES, AGES clinical scoring system. They're all of the same things actually. It just points out to what they look at. So if it's the AMES clinical scoring system, the A stands for age. As we've said, the older the person, the more worse the prognosis is. Younger people have a better prognosis than older people. But of late recently, authorities are believing that extremes of age may have a bad prognosis. Also, the D, the M is metastasis, distant metastasis. So the further it spread, the worse the prognosis is. And E is the extent of the primary tumor. So just within the thyroid gland, how extensive is this tumor? And the E stands for size of the primary tumor. Of course, we know the larger the size, it makes the prognosis become worse and difficult to deal with. So that is it for the AMES clinical scoring. And that's for the AGES clinical scoring. A is for age, as I explained the same. G is for the pathological grade of the tumor. E also for the extent of the tumor. And the S is for the size of the tumor. So, just to recap with regards to this prognostic risk classification, as I said, when they're less than 40, it's a low risk. When the patient is more than 40, it is a high risk. The gender, well, as I said earlier on, females do have less risk than males. So if you're a female, you have a low risk. If you're a male, you have a high risk of contacting this cancer. The size of the tumor. Tumors less than 2 centimeters has low risk, and tumors that are greater than 4 centimeters, they have high risk. The metastasis. Low risk don't metastasize. So for low risk patients, there is non-metastasis. And for high risk patients, there is either regional or distant metastasis. The grading. If it's well differentiated, then it's a low risk tumor. But if the differentiation is poor, they're poorly differentiated, then it's a high risk tumor. What about the extent? Of course, as I said, when the extent is just limited locally, no local extension, intrathyroidal, no capsular invasion, then it's a low risk. But if it's a high risk, then it should be poorly differentiated. There should be capsular invasion, and it should be extrathyroidal extension that is out of the thyroid gland. So that's it for the follicular carcinoma. So our next type of thyroid carcinoma is the medullary carcinoma. As I said, these are from the parafollicular cells, the C cells. So what are the clinical features of this medullary carcinoma? They are capable of secreting calcitonin, carcinoembryonic antigen, histaminase, prostaglandins, serotonin, and other peptides. What's the significance of this? When you do a blood test, you look for these things, and they will be high. They will have a high blood serum. This will give you an indication that it's a medullary carcinoma. Another feature is that the thyroid swelling There can be thyroid swelling within the neck, and also the neck lymph nodes can be enlarged. This tumor is very aggressive than the papillary and the follicular. So it gives an indication of the prognosis. It is very aggressive. It extends to the cervical lymph nodes and the surrounding tissues. So when you see there's an extension, the cervical lymph nodes are being involved and surrounding tissues, start to give an indication of a medullary carcinoma. Medullary carcinoma may also invade the lymphatics. It may invade the blood vessels. It may metastasize to the liver, the lungs, and other viscera, and may present with the corresponding symptoms. As I said, the further the extent, the more worse the prognosis is. And as we've indicated, this is very aggressive, and so it can spread in almost all the different medium. 80% of medullary carcinoma, they occur sporadically, whereas 20% occurs as a familiar type. And this familiar type, they have two patterns. We have the one that we call the follicular medullary carcinoma without associated endocrine disease. And the second one is associated with the multiple endocrine neoplasia 2A, which consists of the medullary thyroid carcinoma, pheochromocytoma, hyperthyroidism. And the third one is the MEN 2B, which is sometimes referred to as medullary endocrine neoplasia 3. And this consists of the medullary thyroid carcinoma, pheochromocytoma, multiple mucosal neuroma, intestinal ganglioneuromatosis. So just to recap with that, 20% of the medullary carcinoma occur as a familiar type, whereas 80% occurs sporadically. And of this 20% that occurs familiar type has different patterns, as I indicated to you. Good. Now we go to the next form, which is the anaplastic carcinoma. The anaplastic carcinoma, as the name implies, it has a rapid progression. It is firm, it is hard, and it can be fixed to the tumor. So for this, it is fixity to the skin. So you look for these features and it starts to give you an idea of an anaplastic carcinoma. It usually occurs in older patients. And when patients have an anaplastic carcinoma, stridor, hoarseness of the voice with tracheal obstruction is a feature. Of course, hoarseness of the voice is suggestive of the current laryngeal nerve is being obstructed and stridor. And also it can present with dysphagia, fixity to the skin, as I said, and also there is a positive berry sign because the tumor grows so large and it engulfs the carotid sheet. And because of that, pulsation of the carotid sheet will be absent. As from all features, it suggests that it is very aggressive with a poor long-term prognosis, and the 5-year survival rate is 7%, and it has a mean survival of 6 months after diagnosis. So with this summarization of the thyroid carcinoma, I believe as clinicians and endocrinologists, whenever we are faced with this kind of patients, we'll be able to make an adequate diagnosis and be able to treat the patient appropriately and correctly, because as I said in recap, it is the most common endocrine malignancy and the 7th most common cancer in women. Thank you very much for having my attention.